We will go ahead and get started. So, good morning, everybody. Thanks for joining us remotely and here in Boston. We are joined today by Dr. Karl Misulis. He is a practicing neurologist in Jackson, Tennessee, with West Tennessee Neurosciences, a group which he helped found.
Has joined the conference.
He earned his MD and PhD from Vanderbilt University, where he completed his residency and remains on staff as a clinical professor. While formerly a researcher in toxicology and neuro-oncology, Dr. Misulis
has joined the conference.
Now focuses on stroke prevention in his clinical practice. He has published 16 books and has lectured around the world. And Dr. Misulis will speak to us on acute stroke therapy this morning. So welcome, Dr. Misulis.
Thank you so much for having me, and if you need me to pick up the phone, I'd be happy to, but it's a pleasure to be with you today. It's been an honor to be listed by Best Doctors, and it's been a privilege to work with them over these past years and doing consultations and such. Well, as already mentioned, I'm Karl Misulis. I'm a man with one foot in academia and one foot in, as they say, the real world. I am a neurohospitalist, a hospital neurologist at a large public hospital that is a Vanderbilt affiliate. And in addition to that, I do lots of teaching and such, as you've already heard. What we're going to talk about today is acute stroke therapy, and we're going to focus predominantly on what I think is important for the typical hospital, community hospital like ours, to be able to provide in terms of optimal care. So we're going to be concentrating predominantly on ischemic stroke. We're going to start off with an overview of stroke prevention, and then we're going to talk a little bit about emergent evaluation and what I expect that stroke centers as well as community hospitals should be able to do. We'll talk about management options, medical management, surgical management, which is uncommon, plus interventions, again, focusing on medical managements that are available around the world. And then we'll do a few scenarios, a few case studies, which is, of course, the way that we all learned when we were in medical school and nursing school and such. And then we're going to end up with some secondary prevention recommendations and a bit of a discussion about what we're doing here. Now, I want to tell you that in addition to these fabulous slides that you've been provided, by the way, we don't charge extra for the sarcasm, the American Heart Association has published specific guidelines, and I'll give you recommendations at the end as to how to get a hold of those, but they're free. You can download them from anywhere in the world. If you have difficulty with understanding any of those recommendations, if you have questions then I think you can communicate to me through Best Doctors, and I would be more than happy to try to give you my thoughts and my advice. As my wife gave me a coffee cup, everyone's entitled to my opinion. So let's go ahead and talk a little bit about what we need. We're going to go for about 45 minutes or so with a discussion, and then we'll have some time for questions and some further discussion. Well, what do we need in order to be a stroke center? And in fact, most stroke services are given at places that are not stroke centers. Most of them are community hospitals. So essentially now we have a stratified level of care, but we expect that every place will have an ER staff that is not only trained in general medicine, but an ER staff that is trained in how to evaluate stroke. So most of our ER docs are certified with doing NIH stroke scales. Our nurses are as well. Now, we participated with stroke studies and such, including the TPA study for NINCDS, but that you don't have to have done that, and you don't have to be able to do that in order to give expert stroke care. We, of course, have to be able to get labs available stat, including specifically COAG, CBC, CMP. CT scan of the brain has to be available stat in most hospitals, including community hospitals, have at least one of those available in the emergency department. TPA should be available. We don't use other thrombolytics presently. TPA should be available for intravenous use, and you need to have some sort of stroke coordinator. What we have asked our affiliated hospitals as part of the Vanderbilt network to have is someone who at least is partially tasked with being a stroke coordinator, and this is typically a nurse. Here at what we call the mothership, where we have more than 1,000 beds, we have a nurse who is full-time dedicated to that process. But in the community hospitals with 100, 150 beds, they may have someone who has their fingers in nursing administration as well as able to make sure that all of our dysfunctional colleagues are able to be oriented on how to take care of strokes. So a stroke coordinator is helpful even for a small place, and again, it does not have to be a place that is a stroke center. I do want to mention that for those ER staff and for the nurses that are wanting to make sure that they're up to speed on how to do everything from NIH stroke scales to Glasgow coma scales, There is on the iPhone or iPad a neuro toolkit, neuro tools. Kent Ellington, who is like me, he's half-time at University of Texas and half-time is a practicing hospital doc. He has published this and is fabulous, and I encourage you to think about that. By the way, the pictures of this ER staff here is actually my band. I am a rock musician, and we have a vascular surgeon on the left. There's me next with the gloves. There's our lead singer, who's a politician, in the back. Every hospital needs that. And then we have the rest of our medical staff here. I, of course, am wearing gloves because a guitar does not like to be touched by someone who knows how to read music. Now, what types of acute strokes do we deal with? Well, the acute strokes that we most often see are arterial strokes, and this is where we have obviously blockage of the arteries as opposed to venous strokes. Venous strokes tend to happen in people with hypercoagulable states and pregnancy and such, and we're not going to talk about that today. That is much less common and more difficult to deal with in my mind. Transient ischemic attack, we will talk from the standpoint of the fact that some TIAs are actually small strokes. Now, there was a term used, RIND, reversible ischemic neurologic deficit, that was discussed years ago. That is a clinical procedure or clinical syndrome and not really a diagnosis that we make nowadays. If you have symptoms that last longer than 24 hours, chances are you actually have had a small stroke, and you may clinically get over it, but you had a small stroke. In fact, if the symptoms of a TIA last longer than 1 hour, the chances of there being actual ischemic change are much more. And then we have intracerebral hemorrhage, and although we're going to talk about that in the focus of complications from stroke, we're not going to discuss that in depth today. Again, that'd be another issue for another time. So the clinical presentations that we deal with, the one that we like to see the most is when we see someone fairly acutely after the onset of neurologic deficit, and our first scenario will illustrate that. This is someone who you can give TPA and consider the possibility of neurointervention because you know exactly when the deficit began. The problem is when you awake with a deficit, you don't know whether the deficit developed 1 minute before they awoke or 1 minute after they went to bed the previous night. So if they awake with a deficit, they're typically outside of the time window to do either intravenous or intra-arterial thrombolytics. A gradual onset of deficit may be considered to be atypical, but is actually seen more commonly than we appreciate and is usually due to propagation of thrombus, edema around the area of the stroke, sometimes other complications from the stroke itself. And then a stuttering defect, deficit, where someone may have weakness that gets better and worse on a basis of every day or even several hours. That is quite typical of some lacunar infarctions, subcortical infarctions, but can be seen with cortical infarctions as well. When that happens, we tend to get nervous. What do we need to do? And unfortunately, our options are quite limited. Now, there are some atypical presentations of stroke, and all of these can present as stroke. Confusion, for example, visual loss, vertigo, peripheral facial palsy. Now, taking one at a time, in our hospital, the most common cause for neurologic consultation is stroke or TIA. The second most common cause is confusion, and a certain proportion of those will have it on the basis of focal or multifocal infarction. Those people, especially depending upon the location of the lesions, may have no focal findings to suggest to you that they have a focal deficit. Now, visual loss as well can be something that is easily missed on the casual examination. So if someone has a hemianopia, loss of visual field to one side, then they can be easy to miss, and frequently those patients present with confusion, some memory difficulty as well. As part of my neurologic practice, this is one of the most common signs that's missed by my primary care colleagues, even at a teaching institution where I work. So multifocal infarction, or especially posterior cerebral infarction, can produce these. Vertigo is usually a peripheral vestibulopathy, but every once in a while can be an atypical presentation of stroke, brainstem stroke specifically. Almost always you will have some other symptoms in association with this, symptoms such as unilateral ataxia, diplopia, and such. Now, vertigo can be extremely severe when it's peripheral, and those of you that have had this, like I have, may have had the thought of, how can this possibly be a peripheral process? I must be having basilar thrombosis. But peripheral vestibulopathy can be extremely severe, so severity by itself does not help with the diagnosis. It's a matter of other associated symptoms. Now, what about peripheral facial palsy? As we were going through our education, we got trained that it was a stroke if the lower face was involved. It was a Bell's palsy if the upper and lower face was involved. And generally, that usually is the case. However, you can have, through some upper pontine lesions, damage to the facial nerve, so as a result you can have a peripheral facial palsy. So in that case, again, you will have other signs and symptoms in association with this. So this is one of those situations where they can be atypical, and whenever you see an atypical presentation, you need to be concerned about the possibility of an alternative diagnosis. In fact, when you see someone who has a stroke, you have to think about alternative diagnoses anyway. Well, what is not an ischemic stroke? Well, the first thing would be a non-ischemic stroke. Intracerebral hemorrhage, which will be one of our cases today. Subdural and subarachnoid hemorrhage, of course, are presenting occasionally with stroke symptoms. They usually present more with headache and decreased level of consciousness, but they can give symptoms of acute ischemic stroke. A seizure or a postictal period can sometimes look like a stroke, but it's not. An example would be someone with a non-convulsive seizure. I don't mean non-epileptic, where it was psychogenic, but where it was actually non-convulsive, where there was ictal paralysis. This is quite uncommon, but in our busy practice, I would say once or twice every 6 months, we will see a patient who we diagnose with having ictal paralysis. We're probably missing more diagnoses than that because we don't always look. Postictal period can be associated with focal findings that may or may not correlate with a focal structural lesion in the brain. Person may have an unwitnessed seizure, they may be amnestic for that, and then present subsequently with focal weakness that gradually resolves. You may think they had a small CVA and such. Now, multiple sclerosis usually does not present with the kind of acute onset of deficit that you would expect with a stroke, but still you can have an onset over hours to a day or so it can look like a stuttering or progressive stroke. Migraine is a complicated situation because patients with migraine can present with hemiplegic migraine, or they can have auras or associated neurologic symptoms to suggest that they're having focal structural circulatory abnormalities. In addition to that, though, patients with migraine have a higher risk of actually having an infarction, migrainous infarction. Even after they have grown out of the migraines, they may still have a higher incidence of having stroke in their later years. So migraine is a funny thing, and every once in a while we'll end up giving TPA to someone who ultimately turns out to have had a migraine with neurologic deficit. Hypoglycemia can give not only decreased level of consciousness, but also focal findings, and this is especially common when the person has had a structural problem in an earlier stage, but it is quite prominent how focal you can see the deficits that then promptly improve. So always check for that, even if you do not know that the person may or may not be diabetic. Mass lesion can present with an acute deterioration if there are secondary vascular changes or edema, and you may have lesions that may be in an area that do not produce prominent symptoms until they get worse.
Has joined the conference.
Intoxication is a particular friend of ours in Tennessee. Of course, we all know that a little bit of alcohol may be good for your cardiovascular system, so my fellow Tennesseans have embraced that, figuring that if a little is good, a lot may be even better. So we end up having patients come in who are intoxicated on either alcohol or some other issue, and they may present with ataxia, diplopia, perhaps even a Wernicke syndrome, where it looks very much like a parenchymal brainstem problem, for example, and it is not. And then peripheral vestibulopathy, we've already discussed, that even from my own personal basis can be quite disabling. Conversion reaction is common, and we will see this especially in times where stresses and such have gotten to the point where they have caused the person to call for help frequently in a way that is neurologic, whether it be non-epileptic seizures or whether it be a non-organic weakness. Making the diagnosis of a conversion reaction is fraught with a little bit of risk because not infrequently a patient who you feel has embellished their examination turns out to actually have a perhaps more mild deficit that you could easily miss. So always keep in the back of your mind that you or I may have missed that diagnosis. We know that we're not perfect. Now, what are our ways that we try to evaluate patients with suspected stroke? And of course, the paramedics are doing much of this, the ABCs, of course. Let me mention about the brief initial survey. This is something that wasn't taught to me when I was in medical school. The idea is that you would go to see that person, you would do the comprehensive 45-minute history and examination and come up with a synthesis. Well, we have to work faster than that nowadays. So when you go into the emergency room, whether it's to see a neuropatient or not, you do that a brief initial survey. Hi, I'm Dr. Misulis, and what is the problem? While you're examining the strength, listening to the belly and the chest and so on, you're getting that brief 1-minute, 2-minute survey to find out what the problem is, putting in a few orders on your iPad, and then when we've already started the protocol for evaluating that particular problem, then we go on to a more detailed history and examination. NIH stroke scale is done multiple times in every patient that comes into our facility, and as well as in most with stroke symptoms, and can be done by forms that are typically in the electronic record or in paper forms, but can also be done using that tool for the smartphones that I already mentioned. Laboratory studies, if you think someone's having a stroke, are electrolytes, glucose, CBC with platelets, coags. EKG is routinely done. What about cardiac enzymes? They're frequently done, more so often than our cardiologists would like, because that frequently results in some sort of troponin consult. CSF is seldom obtained unless you think the person has infection or unless you think the person has had a subarachnoid hemorrhage. Then, of course, imaging. You knew we were going to get to that. CT brain is standard, and we typically start with that when someone comes in with a deficit to make sure they don't have a hemorrhage. And then, if they meet all of the other inclusion and exclusion criteria for TPA, we'll move on that, and then we'll typically get a CT angiogram with perfusion study. Not all of our facilities have the availability to do CTA and P on demand in the ER. That's okay. Now, many facilities have the resources to be able to do MRI brains in the emergency room as part of the initial evaluation, and this certainly is extremely valuable if you can do that, but you don't want to slow down the early evaluation and treatment, especially if you're going to think about TPA or some sort of other intervention. We at our city hospital, our large city hospital, do not have the ability to do that, although we will typically get the MRI brain later in the day. What about catheter angiography? It's not part of routine care, but a couple times a week in our busy practice, we will have someone who gets neurointervention for a stroke where they may be a candidate for intra-arterial thrombolytics or some sort of the thrombus retrieval device. Well, the emergency management typically includes anti-thrombotics. If someone is not on any antiplatelet, as soon as the CT is okay, and depending upon whether they're a candidate for thrombolytics, we'll give them an aspirin, 325, and then move on from there. Thrombolytics, including mainly TPA, we'd like to use whenever possible. I do want to mention a couple things about that. We only use the RTPA. We don't tend to use the other thrombolytics. Maybe the vampire bat saliva will be effective at some point, but that at this point we try not to go beyond the clinical indications. Also, that we have extended the time window for giving TPA intravenously under certain circumstances. And so that if the person presents with the inclusion and exclusion criteria within 3 hours from when they were last normal, then you can go ahead and give them intravenous TPA. And we'll even start that in the scanner room if necessary. Now, if the person is under the age of 80, and if the person does not have a history of stroke and diabetes together, you can extend that window to 4.5 hours. However, I don't want people in my emergency room then to think that they can slow down on their evaluation, because the response rate is dramatically different based upon whether you give it within the first 90 minutes, the second 90 minutes, or the third 90 minutes. In fact, between the first 90 minutes and the third 90 minutes, the 3 to 4.5 hours, then you have more than a twofold improvement in outcomes numbers. So it's important to do that. Now, what about intra-arterial interventions? And this is an area that is in flux now. And we do have neurointervention available 24 hours a day. Most community hospitals do not have that. And that's okay, because the key is giving the intravenous antithrombotics, thrombolytics, and giving antithrombotics if necessary. Now, the intra-arterial interventions are given if you have an acute thrombus that's identified in the CT angiogram, you have a perfusion defect that suggests that you may benefit and salvage this area. Again, I'm not going to go into all the criteria. This tends to be determined by the interventional neuroradiologist, which, if your facility is anything like mine, can differ from individual to individual. Now, the hospital management includes the Tennessee triad of hypertension, hyperlipidemia, and hyperglycemia, but blood pressure getting too high or too low can make strokes worse, of course. If you're going to give TPA to someone, you need to get the blood pressure less than 185 over 110. If you're going to treat the person with antithrombotics and not give TPA, we tend to let it auto-regulate to up about 220 over 110 to 120. Now, glucose, hyperglycemia is not only a problem, but hypoglycemia is as well. And then we'll check lipids, and we'll give the majority of patients a statin if they're not already on one. One element I want to discuss a little bit is about hypotension. We're very aggressive about being blood pressure in our patients and ourselves. However, if we bring the blood pressure down excessively, even to normal, not even below normal, in a patient with stroke, you may extend the stroke because of decreasing perfusion pressure over an area of stenosis. Don't forget about feeding, but make sure that you've done swallowing studies or swallowing evaluations, that they're not going to aspirate. Watch out for fever because any degree of hyperpyrexia makes outcome worse. Get therapy started. We typically have the therapist evaluate the patient on the first day if it's during business hours and start therapy on the next day unless they're unstable. And then surgery is almost never needed, but that we'll talk a little bit about that in one of our scenarios. And then on our post-discharge management, we focus on risk reduction, and this is where in Tennessee, I love Tennessee, but that we particularly fall down because we have a great infrastructure for taking care of acute hospitalized patients with stroke, but we do not do a very good job, dare I say lousy job, about making sure that all of our patients are followed up on and get all their medications that they need to be able to reduce the risk of having to come in again. And then therapy after they got out as well. So let's talk about a couple of scenarios, and that I'm going to talk about 5 scenarios that illustrate different aspects of some of the issues that I've introduced in this first little section here. Now, the first is a 48-year-old female who presented with an acute onset of right hemiparesis and aphasia. She had a dense right hemiparesis and she had a global aphasia. She actually was an employee of our healthcare system. She was on campus in an adjacent building, and she had this, was observed by her colleagues, and so by the time she arrived in the emergency room, it was less than half an hour from onset of her symptoms. Her past history was remarkable for the Tennessee triad of diabetes, hypertension, and hyperlipidemia. Her examination showed the right hemiparesis, essentially hemiplegia, and global aphasia. Her CT scan of the brain, as shown in this study, looked normal. She met the inclusion and exclusion criteria for giving TPA immediately, and so that was done. As this was hanging, we got the CT angiogram and the CT perfusion study, and this shows the perfusion study. On the left side of the brain, the right side of your image, we see the bluish area, and that is a large area of reduced perfusion. This is an area that is susceptible to deficit, and if we can get circulation back to here, we need to try to do that. So we also did the CT angiogram, which showed severe left internal carotid artery and distal thrombus in the middle cerebral artery with that defect. So she was potentially amenable to tandem treatment with intervention. And in this case, this is the angiogram showing the marked stenosis of the left ICA, internal carotid artery, on the left-hand side of the screen, and that's quite evident right at the middle. In addition to that, there was thrombus that I'll show in just a second. She was given a stent to try to help to open up this. Now, normally you wouldn't put a stent in with acute stroke. However, the interventional neuroradiologist could not get up to the middle cerebral artery lesion without doing the stent first, so they did that, and then they went up, and then they worked on the middle cerebral artery stenosis, which is shown here. On the left side of the screen, you see the middle cerebral artery essentially stopping as it goes up to the left side. So in her case, this illustrates that she had the acute onset of stroke. She was a candidate for intravenous TPA, and she was a candidate for intra-arterial intervention as well. Well, is that necessary? Is it really necessary to give both intra-arterial and intravenous? And although we have done this, and we still do this occasionally, we're less likely to do so. The IMS-3 study, Interventional Management of Stroke Study 3, has preliminarily been stopped because of no benefit of the combination of intravenous and intra-arterial therapy. So although we're waiting to get guidance from other stroke centers and from consensus that we're likely going to be less likely to do both. So if you can give IV, go ahead and do that. Well, is there a candidate where someone might be able to get intra-arterial and not get intravenous? Well, it turns out that if people who have had certain problems such as some sort of surgery in the extremities or in the belly where you can't give intravenous TPA, that's an issue. But timing is the main factor. Although we're limited to 3 or 4.5 hours on giving intravenous TPA, many facilities will give intra-arterial TPA and device retrieval up to 6 hours and sometimes even longer. So as a result, we have a longer window for that than we do with the intravenous. Now, all right. Scenario 2 is a 50-year-old female who had stepwise progression of left-sided weakness. This started on the day prior to her presentation, and she noticed that her left hand wasn't working right. Now, she is a health nut. She's trim as could be. Again, an anomaly for my area. She exercised all the time, but she unfortunately had some medical problems. So she had breast cancer that was actively undergoing chemotherapy at the time, plus she had a history of an MI secondary to marked hyperlipidemia, genetics, and such a year prior to this, despite her taking such good care of herself. And she was afraid that she might have a metastasis, so when she developed difficulty with her hand, she passed it off, not wanting to get it evaluated. Well, she got worse overnight. She developed a mild left hemiparesis without any neglect. MRI of the brain showed what it does on the right side of the screen, which is that white area on the lower left-hand side of the image, the right side of the brain, which is in the distribution of the posterior division of the middle cerebral artery, a right parietal infarction. This is acute ischemic change. Now, in her case, the consideration was, did she have a thrombus that happened because of endocarditis? Was she hypercoagulable from her breast cancer? It turned out that she had carotid dissection, and perhaps all of those aerobic activities and such that she was doing may have made this worthwhile. But this is a carotid ultrasound showing that in the right ICA, right internal carotid artery, that she had separation of the layers in thrombus, active thrombus with near occlusion in this. Here is the MRA showing that you essentially had no flow that you could see on MRA, but on carotid as well as on angiography, you could clearly see that there was some flow. Now, because she had cancer and because she had symptoms that started the day prior to this, she was not a candidate for intravenous or interarterial TPA, again, largely because of the timing. Someone has a cancer that you think is high likelihood of bleeding, lung cancers and such, then again, we in any patient with cancer, we are extremely unlikely to offer them therapy of any kind in terms of thrombolytics. In terms of anticoagulation, and patients with dissections, at the time that we saw this patient, about a year ago, we immediately anticoagulated her with heparin. We changed her over to warfarin, and then after about 6 months, when she reestablished good flow going up through that side, we took her off the warfarin and ended up with her antiplatelets, and she's done well. Luckily, because of the breast cancer as well as because of her stroke. She's essentially back to where she was. She's done quite well. Well, is it worthwhile to go ahead and anticoagulate these folks? The cervical arterial dissection and stroke study, CADISS, showed no definite benefit of anticoagulation over antiplatelets with dissections. However, this is where the patients weren't started on the anticoagulation until 11 days after the event. So in terms of whether long-term anticoagulation is necessary, there is a little bit of comment about that now, but this did not answer the question as to whether we should anticoagulate the people immediately, so we're still doing that until we learn otherwise. Scenario 3, this is a 66-year-old man who was found down with decreased response and with left hemiplegia. Now, he had a history of stroke in the past, and he had a right hemiparesis with this. By the time he presented to the emergency room this time, his INR was 1.3, so he was not adequately anticoagulated. Now, one of the things that we're not going to discuss so much is that when you use warfarin for stroke prevention, you have to have an eye on how much time the person is actually anticoagulated. If the person is fully anticoagulated adequately, not too high, not too low, less than 60% of the time, then you're likely not getting the benefit from the warfarin that you think you are. Nevertheless, this is a CT scan done 3 days prior to the presentation in the emergency room this time, and this shows lucency in the left side of the brain, right side of your image, which is from his previous stroke from the previous year. And the overwhelming consensus was going to be clinically that this patient had presented with not being anticoagulated adequately and now having recurrent stroke, this time on the other side. Well, luckily, we're not at the stage of trying to give TPA in the field. I don't think we'll ever get to that because of this. He did not present with many of the typical symptoms of intracerebral hemorrhage, but he had a large right intracerebral hemorrhage. He was clearly not a TPA candidate, of course. What are the options in this case? Well, he was quite devastated from his previous left hemisphere stroke. Now he was devastated from his prominent right hemisphere strokes. So the surgeons rightfully decided that they weren't going to offer evacuation, although there was some shift in his circumstance. Well, now, one of the issues that this brings up is how do you differentiate between ischemic stroke and hemorrhagic stroke? Well, you have to do a scan, but there are some general clues of what can give you an idea that the person has had a hemorrhage. Headache, nausea, vomiting, and decreased level of consciousness are the typical symptoms that suggest hemorrhage versus ischemia. The ones that are the most specific are nausea and vomiting. Headache, although that's more common with hemorrhage, it can be seen in ischemia as well. Decreased level of consciousness, again, can be seen in both, especially in this man who had bihemispheric ischemic changes or bihemispheric strokes. So as a result, we don't want to give TPA without absolutely knowing for sure that we have had this. In terms of that, the occasional person with subarachnoid hemorrhage may have a CT that only shows small amounts of blood that can be missed by some radiologists, so we do have to keep that in the back of our mind. Now, scenario 4 is a TIA. This is a 54-year-old man who had an episode of left hemiparesis that got better over 1 hour. Back to normal by the time he arrived in the emergency room. History of coronary artery disease, history of MI, history of smoking. His examination by that time was essentially normal neurologically, and the CT scan of the brain was okay. All right, well, he just had this episode, and I suppose this could be worked up as an outpatient, but that because we have a number of patients that may say they're going to come back and not necessarily come back, unless it's something that happened days in advance, we'll tend to bring him into the hospital for their evaluation. Well, later on that day, he got his MRI, which showed this, which showed he had multifocal infarctions in the right hemisphere, left side of the image, showing you that even though he was clinically improved, some TIAs are actually CVAs, or actually cerebrovascular accidents. In fact, you will see diffusion abnormalities in approximately 39 to 40% of patients who present with TIA. Well, what happens if the person is admitted with a TIA and that night has a completed stroke? You pull down the CT scan and they don't show bleeding. Are they a candidate for intravenous or even intraarterial thrombolytics? Absolutely. But what if you've already done the MRI and you see that their TIA was actually a small CVA? What would your response be in this case? Well, my response would be, and not everyone that would be in my shoes might agree, but my response would be that if the person has very small punctate areas of ischemic change, then the benefit you would see from the thrombolytics given just a few hours after that would likely be more than the risk. So I would consider that, but I certainly would not fault anyone for saying, no, if I have any ischemic change, I'm not going to do that. Now, the last one is a 60-year-old with acute onset of left hemiparesis, history of diabetes, hypertension, and hyperlipidemia, and the CT scan showed no findings, so was given TPA at the outside hospital and transferred in. Quite common. There's no neurosurgical coverage at many of the regional hospitals, so therefore they will go ahead and be transferred after getting a TPA. Well, by the time they arrived, she was actually much, much worse. And so our thought process was, oh my gosh, she has bled into the area where she got her TPA and such. Now, the incidence of bleeding during the NIN-CDS study was about 6%. In practice, the incidence is less than that. We're better about controlling blood pressure, and we're trying to be very good about patient selection nowadays. But she became much worse, but what she had was not bleeding. What she had was cerebral edema. It may be difficult to see on your monitors, but on the right side of the brain, left side of your screen image is a loss of gray-white differentiation and signs of early cerebral edema. So she became much, much worse because of cerebral edema that happened because of that ischemia. Well, what was the differential diagnosis of her worsening? Well, bleeding would have been the thing to worry about the most. Another embolic stroke or another cause for there to be another event would be another. But in this case, it showed that she had a very large infarction. This is an MRI with diffusion imaging showing that most of the middle cerebral artery, in fact, all of it, has been devastated by this. Well, what options do we have? In her particular case, we advised the family that the prognosis for good recovery of that left side was not good, but this is a non-dominant hemisphere lesion. So in this case, she had edema develop that night to the point where she had to have a craniectomy to relieve the pressure. And although she has improved to the point where she's alive and now she's in rehab, she has a dense left hemiplegia, but she is awake and talking. So in patients with a non-dominant hemisphere infarction with cerebral edema, then they can benefit from craniectomy in those cases. So now, the craniectomy is typically done with non-dominant, not so much with dominant, and typically that cerebral edema will develop in younger individuals, as in her case. She was only 60, that's my age, right? So that's young. So what are the issues that we've discussed? In the first acute stroke one, try to give TPA if possible. If not, use antithrombotics. In scenario 2, the subacute stroke, not a TPA candidate. Don't liberalize the criteria over and above what are already published, and look for a cause. We need to always look for the cause. Under scenario 3, with a hemorrhage, not all stroke presentations are ischemic, and every once in a while an intracerebral hemorrhage or even a subarachnoid hemorrhage may present with symptoms of an ischemic stroke. Scenario 4, the transischemic attack, is that TIA management generally is similar to CVA management, but some TIAs are actually CVAs. And then when there is stroke with progression, progression is common, rescan, find out why to see if you have any treatment options. Unfortunately, up to 20% of patients that are admitted because of ischemic stroke progress, and there's not that much you can do about that. Well, what do we do now? Well, we've got them out in the emergency room. We started their treatment, and we've gone through our different scenarios. We use anti-thrombotics, as we've mentioned. We have medical management, we've mentioned. We talk about therapy. We also do a needs assessment. And then as they're getting ready to leave the hospital, we make sure they're on anti-thrombotics. We make sure they're on statins. We'll talk a little bit about that. We work on risk reduction, which is an area I've already mentioned that we're quite weak on, and self-help guidelines. I emphasize to my patients, regardless of whether it's stroke or seizures or myasthenia or what have you, that medicine is a team sport. I will do my part as a physician, my nursing staff will do their parts, and the patient needs to do their part, and we can't win without doing that. By the way, this is my home away from home, or my wife might say this is my home. This is the hospital where I spend all my days. You can tell I no longer live in New York. We have a blue sky here. Now, let's talk a little bit about risk factors as we finish up. The risk of recurrent stroke is prominent. So I try to emphasize to people that, of course, of a 5-year time period, they have at least a 25% risk of recurrent stroke. In our area in Tennessee, it's higher than that. The risk is quite prominent a month, but there's risk every single year. So anything they can do to lower their risk can be helpful. And so we try to work on that. We would save billions of dollars and millions of lives if we could do that. Every year, we have about 800,000 Americans that have stroke, and we have about 140,000 deaths from stroke every year. I understand those of you that are from the UK, Australia, and such will know that you do much better about that survival rate than we do. That is our problem with especially outpatient therapy. Well, getting on to that, what can we do about these risk factors? In fact, if you're going to be placing your bets as to what's the best treatment, I would say that if you can keep people from having some of these risk factors, that you would do better than perhaps some of the new and fancy interventions that we have nowadays. And this spoken by someone who spent half my academic career as a researcher. TIA or CVA increases your risk tenfold, hypertension substantially, and smoking and ethanol and all down the road. What about ethanol? Didn't we hear that ethanol was good for you? Well, it turns out that you can debate those numbers.
The conference.
There's no doubt that ethanol in high amounts makes the risk of stroke even worse. Try to work on some of those modifiable factors. Now, how are we doing in Tennessee? And this is just to be illustrative of what we're dealing with. If you look at the bottom row, 83% of Tennesseans have at least one significant major stroke risk factors. And if you look at obesity, 62% of Tennesseans have a BMI greater than 25. So the criterion that Tennessee Department of Health uses is 25 instead of 30. Our numbers over 30 BMI are 38%. Smoking is higher than in most states. Hyperlipidemia, hypertension, again, higher than most states. And our Tennessee diet is actually killing us. If we can reduce some of these and make these better, we would reduce the risk of stroke, obviously. Now, what about anti-thrombotics? And I want to spend just a little bit about that. We use mainly aspirin chewed up in the emergency room. It's quite cheap, even here in the United States. We will use Plavix, and I do believe the data does support that Plavix is a bit better than aspirin, but many of our folks have a hard time affording that. We have 11% of our populace that has no insurance of any kind, and they have to spend their money on things that are much more important, like food, housing. Now, seriously, that the money is a process. In fact, even for people with insurance, they may have a limited number of drugs that they can get that are proprietary and still be able to have them afford their other drugs, their lisinoprils and so on and so forth. Now, what about warfarin, Pradaxis, Xarelto, and such? And I would refer you to a reference I'm going to give you at the end of the hour, which talks a little bit about that. Suffice it to say that we use those anticoagulants for routine strokes and TIAs much less than we used to. And patients with coagulopathies and patients with atrial fibrillation, low ejection fractions, were more likely to use these. If the person is on warfarin and they have an INR less than 1.5 to 1.7, they may be a candidate for thrombolytics up to 3 hours, but that all bets are off if you're on Pradaxis, Xarelto, or those, because it's harder to monitor where you are sitting at with those. Now, what about the statins? This is from the Northem Manhattan Study. This is the same study that came up with the alcohol data that I mentioned a few minutes ago. That clearly, without going through the bars time and time again, I'm sure you're familiar with these, that there is a reduction in severe stroke, mortality, and the chance of worsening when you use statins. What's not shown on this was part of a different study, is that if the person comes into the hospital and has to go for endarterectomy or another vascular surgery, their complication rate is lessened by being on a statin even during the time that they were in the hospital. So we'll typically start that even the first hospital day. Well, blood pressure I mentioned already. We have a higher incidence of blood pressure, and we're particularly bad about that here. Approximately 80% of Tennesseans with hypertension are uncontrolled. So here in this pie graph, you have 18% that are controlled, 17% that are on med but uncontrolled, 34% who know they have hypertension and are not taking medication. These are the people who are looking for the Darwin Awards. And we have 31% who do not know that they have hypertension to begin with. So with more than 80% of Tennesseans with hypertension being uncontrolled, that is the reason why we have almost twice the stroke risk of the rest of the country. We are part of the stroke belt going across Tennessee and the Carolinas and such. And we have a little more than 11 stroke and TIA admissions per day at this public hospital. Now, smoking is an issue, and we have a hard time getting people to quit that. My wife was a cancer researcher herself, and she figured that if she were to get people to quit smoking maybe 1 or 2 a month, she would solve more lives than all of her years as a cancer researcher. Well, it turns out that we can't get them to quit. The labels that we have in the United States are not quite as dramatic as these. This picture is from the Amsterdam airport. I like particularly the smoking can cause a slow and painful death. We're a little bit more diplomatic. I know you may find it hard to believe that we're going to be diplomatic, but we are diplomatic where we shouldn't be. So what is our summary? Our summary is that on acute stroke management, the key is rapid evaluation. We have to be trained to the point where someone comes in with a stroke alert or a neuro alert, as we call that. The person is evaluated immediately by a physician, and then the nurse comes in, the NIH stroke scale is done, they're gotten around for their studies. We try to make sure we have the right diagnosis. Now, every once in a while, you're going to treat a conversion reaction or a migraine with TPA. Luckily, the risk of that is low. Better to err on that side than to not give TPA or other anti-thrombotic agent when the person does have a stroke. Emergency management is the key, and we use these tools that I've already mentioned to help out with streamlining their care, and we even give them continuing medical education CME credit for them reading the articles that I will refer to and making sure that they're up to speed on that. We do not have the resources, even though we have house staff and medical students, we do not have the resources to have someone neurologically posted in the emergency room 24 hours a day, but we do have 24-hour coverage, so we require the ER staff, their fellows and residents to get going, and then we will get involved subsequently, but not wait for us, but they'll discuss it with us. Then the hospital care we've discussed, needs assessment is key, clinical follow-up is key, and then risk reduction, the anti-thrombotics, the statins, the medical management, and then the self-help as well. Now, for those that want to download these PDFs that cover some of these data, that you can go to stroke.AHA-journals, American Heart Association Journals.org, stroke.AHA-journals.org, and under the left side you'll see AHA resources, and then you'll see a link that says Scientific Statements Guidelines. Click there, and you'll see a couple of different ways of organizing the guidelines. And even easier way is to Google AHA stroke guidelines, AHA stroke guidelines. One of the results will be my.americanheart.org, and you can see where these guidelines are. And then for those that do not do the NIH stroke scales, Glasgow coma scales, and such as often as you think you need to, consider some of the tools like the Neuro Toolkit of Dr. Ellington that I've already recommended. I'm going to go there, and I'm actually 1 minute shy of my 45 minutes, and I'll be happy to answer any questions I can. And I would remind you again, if you have other issues that you'd like to discuss, or if you need some additional information, I would be more than happy to be of assistance. I always enjoy that, and I think that you can contact me through the Best Doctors folks, and they can get us in touch. Thank you again for your attention. I'll answer any calls I can.
Dr. Misulis, thank you so much. This is David Harrison, Associate Medical Director in our U.S. headquarters. I guess I don't know if it's a good or bad thing, but we were, our end was muted, so you didn't hear us laughing out loud again and again. I mean, really enjoyed your presentation. We probably would have interrupted it too much. Even though, of course, I mean, especially the epidemiologic data you share is very sobering, but really enjoyed your presentation. I sometimes hijack things because I do have a lot. I'm an internist and a pediatrician at Mass General as well, and I always have a lot of questions. But before I ask stuff. Want to see if anyone either here in the room or any of the folks on the line have any questions or comments for Dr. Misulis. Always give like the 5-second pause for folks to jump in. Well, one comment, just a quick comment. I came in late because I had an off-site meeting, but came in right where you were talking that stroke can present as a peripheral facial nerve palsy, which I said, oh my gosh, because whenever I see someone with a Bell's palsy, I go say, can you raise your eyebrows? And if they can't, they say, you're good, it's not a stroke. So now I need to be a little more careful with that.
Yeah, Millard-Gubler syndrome or Foville syndrome. I'm sure you remember that. I, of course, graduated from medical. I just had my 32nd medical school reunion, so that's deep in my memory. But that we had to pass those for the boards. Can I make a comment? You mentioned something about the risk factors and such. And I used to live in Canada. I used to work in England, and I will tell you that in the United States we are seriously broken because we pile so much into all this fancy research. And I was a researcher for most of my career, but we are doing a terrible job about taking care of the outpatients. You as a pediatrician as well as internist, if we can raise our generation not having fast foods all the time, not smoking, if we can make sure they get their antihypertensives, their A1Cs are in good control and such, you will do better. I will tell you that I would smirk to myself when I would go through the hospitals in Stoke and such, and I would think that, wow, this is not where we are. But they do as well or better in terms of their stroke care because their patients are on their statins when they show up. Their patients had pretty good blood pressure control when they showed up. Their A1Cs were not 10 or 12 at the time. So that from our standpoint, I feel that we have a tremendous amount to learn from the global community because we are not getting our money's worth for the care of patients, and it needs to start with my children, one of whom is a vegetarian, and trying to keep us healthier going in the future. Otherwise, it'll bankrupt us.
Agree 100%, and I think, graphs like the one that you showed where you showed the relative risk of all of these various risk factors, that's also some of the information I feel that people need because, people can say smoking is bad. People can say, it's important to lose weight. But a lot of times people say, well, that's a qualitative recommendation, but I don't know how powerful the risk is. How big of an effect is it? So when I go and tell people, well, there's this very large study over 100,000 women in UK and looked at smokers and saw that on average smokers had an average life expectancy of 11 years shorter. But if people quit by age 35, more than 95% of that excess mortality was lost. People say, wow, 11 years. And we say, yeah, 11 years. And so that, exactly, thank you so much for bringing that up. This kind of, when people realize that, yes, we can throw medicines at people, but it's so much more what they do for themselves. And if there are meds that we throw at them, that they take them, and controlling this can really increase the duration and quality of their life for many, many years. It's a powerful message that I agree with you. We on the primary care end, where I am, we just don't do enough.
Let me tell you a couple of suggestions, the way I approach some of the diet and weight and some of these risk factors. Obviously, we work on smoking. It turns out that the more I nag a patient, I don't see patients in the clinic, I'm just a hospital doctor now, but that the more we nag them in the clinic, the less likely they are to actually quit smoking. They actually end up finding another doctor if they can. Patients' families are the ones that really play a role. So what I will try to do when I see them in the hospital is to try to engage the whole family. Is this something that you folks can do together? Can you go to the gym together? Can you go wherever? Can you quit smoking together? And we'll try to help you with this, to do it all as a team, and they can be self-supportive if at all possible. Same thing with ethanol. About diet, my feeling about diet is that when people think about the diets that are good for you and they try to think about healthy foods, they may get depressed and think, well, I can't have anything that I like. Dean Ornish, obviously famous cardiologist with the Ornish diet, he had this diet that was very low fat, and there was even some evidence in the heart of some plaque regression, I believe. And but people would have a hard time staying on it. They would sometimes feel depressed. In fact, I would say that no one on the Ornish diet ever, this is a joke by the way, no one on the Ornish diet ever died of a stroke. They all died of suicide. So my feeling is that we need to be reasonable about it. So what I try to emphasize is the Mediterranean diet. and not the Neolithic diet or something like that, the Mediterranean diet, which is a good diet with lots of good food that you can love and you can embrace it, and to emphasize to patients that if they reduce their salt intake, if they reduce their saturated fats, if they leave the sausage biscuits alone, their brains will readapt to the new way of eating, but they've got to give it a shot. They've got to exercise and get used to exercising. They've got to go ahead and give this new way of eating and living a shot as well. In terms of weight and exercise, that's a problem. People who are in Boston and both people who are in New York, I'm originally from New York, will have a lower BMIs and they exercise more, but part of it is just their daily lives, whereas in much of the rest of the world where people will take transit or drive their cars, they're less likely to get that. We have built a brand new center for the city, $30 or $40 million to try to help out with health and wellness. But unfortunately, that it's hard to get people to change their habits. I think it's going to have to be a generational issue. And just as you are working with the pediatric folks to try to get them to be responsible adults with their eating and such, that's where it's going to have to be down the road.
Agree wholeheartedly. Any especially comments from folks over in our Madrid office or in Canada?
Are they?
Yeah. All right. Well, then again, Dr. Misulis, thank you again. Really appreciate your presentation. Not only about the specifics of acute stroke management, but obviously hits very close to home for all of us about taking things upstream and preventing strokes in the first place. So again, thank you so much for your time and your great presentation.
Thank you so much for having me. It's been a privilege.
All right. Take care.
Bye, Dr. Misulis. Thank you again.